Hello, everyone, and welcome to our health professional event this afternoon. My name's Catherine, and I'm Director of Services here at Bowel Cancer UK. This afternoon's session is a session on reducing late-stage diagnosis, and we're going to hear from 4 experts in various fields. And this afternoon's session is slightly different to the format that we usually operate during these types of sessions, in that this is much more of a panel discussion. Each of our speakers will speak for about 5 minutes using a couple of slides on the topic for this afternoon. So they're going to cover what the current setting is and what the future direction is in their particular speciality. And when we've heard from all 4 speakers, we'll then open up for questions and a discussion. So without further ado, our first speaker is Dr. Anwar Khan. Anwar is Medical Director at Patient First Social Enterprise. He's a qualified GP and has been running a community colorectal clinic with his consultant colleagues for more than 10 years, and is an expert in the primary secondary care interface and continuity of care in the community for colorectal patients. There were a lot of C's in that sentence and I managed it. So welcome, Anwar. We saw him briefly there. Our second panelist is Dr. Laura Morelli, and Laura is a consultant gastroenterologist and endoscopy lead at Homerton University Hospital. Laura has been the director for North East London bowel cancer screening for over 10 years, as well as being an active member of the London Bowel Screening Centre and a faculty member for the London Endoscopy Training Academy. So a huge welcome to Laura. Third panelist for this afternoon is Philippe Carvalho. He is nurse consultant in colorectal disease with Homerton NHS Foundation Trust and previously the Royal Marsden. As part of his current role, Philippe provides professional support and clinical leadership to several departments and is focused on delivering his trust's cancer workforce strategy and compliance against waiting times. And he is also our National Colorectal Nurses Network Chair. Currently. And then last but by no means least, our 4th panelist is my colleague, Gerard McMahon. He's our Head of Policy and Influencing for the Devolved Nations here at Bowel Cancer UK. Gerard represents the charity on a number of national committees, bowel screening programme boards and pan-cancer charity coalitions. His focus is on ensuring that the voice of bowel cancer patients is heard by key stakeholders across Scotland, Wales and Northern Ireland. So he will be our 4th speaker. So without further ado, I'm going to hand over to Anwar, who's going to take us through his first few slides. Anwar, are you there? Here he is. Here's Anwar. Brilliant.
I'm managing technology. Okay. Thank you for inviting me, Catherine. Yes, I'm Anwar Khan. I'm medical director of the community colorectal clinic, and it's a social enterprise called Patient First. Next slide, please. So we started in 2008, looking at non-2-week wait referrals. We have always been consultant-led. I've always had the belief that there's a reason why people are consultants and people are GPs, so I don't mind working under their governance. It's sited closer to the community, so there's shorter waiting times, there's no parking charges, and we have robust data capture. We're a small organization, and we use that data capture to improve our services. We are getting, providing great value for money because we're less than national tariff. And we basically run what we call a see, treat and discharge model. There's not many follow-ups because they're all seen by either GPs with special interest or consultants. And we're building capacity, as I say, through GPs with special interest, so that I don't want to be doing more than one session. I'm actually a GP, so we get other GPs to become gypsies and increase the workforce, and they go back to their constituencies and promote colorectal issues. We've also actually in 2009, 2010, developed TNS clinics for fecal incontinence. Next slide, please. And as far as I'm concerned, it is about blurring that primary secondary care interface. I know the fuller stock take talks about this, but actually we've been doing this for a while, and it's important that primary and secondary care work hand in glove. Not the same glove, by the way, and we're not a second class service. And it is about benefits both to commissioners and hospitals, because we really want to be promoting collaboration rather than competition. And the streamlined pathway is also less burdensome to patients as well. What we are missing is an in-house gastroenterologist, because I'm actually getting quite a lot of IBD referrals, because our local hospital's got a 200-300 day wait, and it would be great to have a gastroenterologist, but that's not at the moment with us. But we often do diagnose it as part of our own initial investigations, and then have to ask the GP to refer. The other, if I had a fairy godmother, I'd probably also want a stoma nurse as well. And what I really would like is actually specialist registrars coming to work in the colorectal community, because I think they'll learn a lot, particularly around communication, maybe not so much colorectal issues. Thank you very much for listening.
Brilliant. Thank you very much, Anwar. And we'll be hearing back from you in a few minutes. So next up we have Laura. Welcome, Laura. You can see Laura's slides. Can we see Laura? Turn up. I can't do your slides. Yes, Laura's here.
Hi, sorry, it was doing a countdown. Hi, everybody. Thank you for inviting me. As Catherine said, I'm a consultant gastroenterologist and endoscopy lead at Homerton Hospital, but I'm also director for North East London Bowel Cancer Screening Centre. So today I'm going to tell you what is the current setting and the future direction for bowel cancer screening. At present, as many of you, I believe, already know, bowel cancer screening, we invite all the population at the moment between the age of 54 and 74. It may be slightly different across the country because we invite everybody between the age of 60 and 74, and we are now, at least in London, on a third year of a 4-year phased age extension, and we currently invited from 54 to 74. This patient will receive a FIT kit that, as you know, is a stool sample that look for human blood in the stool, and if that's positive, which in screening means having a level of FIT above 120, the patient gets referred to our lovely SSP clinic, our specialist clinic practitioner, and if the patient is willing to go ahead and doesn't have any contraindication to colonoscopy, they get booked to have their colonoscopy. Next slide, please. What is the future direction in bowel cancer screening? As I told you, we're already in a process of age extension, and in different parts of the country, we are different phase, where basically we are trying to age extend down to the age of 50 and ultimately invite all the population from the age of 50 to 74. In North East London, from April this year, we're already inviting the 54, and from last year, the 58, and the year before, the 56. And we are on track to invite both 50 and 52 in April next year to complete our age extension. Another new thing that we're going to go very soon, because it's actually supposed to go live on the 5th of July, unless at that last minute delay, we're going to also start to deal with surveillance for patients diagnosed with Lynch syndrome within the bowel cancer screening program. And that's because we can provide a better, robust way to control these and deal with them, and also a higher quality colonoscopy. This patient will be invited directly for an assessment, the SSP clinic, and a colonoscopy every 2 years, so without the FIT test, from the age of 25 or 35, this depending on the subtype of Lynch syndrome they have. And more in the future, the idea is that we are trying within bowel cancer screening to lower the cutoff, which we consider positive, our FIT test. At the moment, I told you the cutoff is 120, but the idea is that to make it much more effective, we should lower the threshold to 80, and also to be more in keeping with the rest of the Western and European country, where it's more around 50 to 80. Obviously, the issue with that is not that we don't want to improve our tool, but it's that if we lower the threshold, we also increase the demand on colonoscopy capacity. And unfortunately, at present, especially outside London and the rest of the country, endoscopy has a huge backlog within symptomatics, and endoscopy capacity is really, really stretched. Well, we calculated that to be able to lower the threshold and do bowel cancer screening in everybody with a FIT above 80, we need to reduce the symptomatic colonoscopy demand by 35%. And that means a huge work in time to make all the requests for symptomatic colonoscopy more appropriate. And that's why we're working on pathway through 2-week wait and straight to test to try to make those requests more appropriate, avoid the one they're not required, and therefore create some capacity to do more screening with a better cutoff and find bowel cancer early. Thank you.
Brilliant. Thanks, Laura. Lots there. I'm sure we're going to have lots of questions about the future of screening, because there's big change heading our way, isn't there? Okay, next up we have Philippe. So I'll wait. I won't hassle you because I now know there's a countdown. There you are. Over to you.
Thank you, Catherine. Thank you for that great presentation, and thank you to Bowel Cancer UK for organizing this event. Hello, everyone. As mentioned, I'm Philippe. I'm a nurse consultant in colorectal disease, and I'm also the chair for the National Colorectal Nurses Network. So I thought, for the interest of this presentation, it would be great to put on paper a model of care for a STT service, or straight to test, or a 2-week wait, so we can use for reference. Now, the model that I'm going to talk to you is the model we have here at the Homerton, and not by any means it's a perfect model, and not by any means it's not a model that still requires development and improvement. But I thought to keep the ball rolling, to get the conversation going, I thought it would be useful to talk about the model currently implemented here. So for our straight to test or 2-week wait pathways, we get the referrals, most of them via the GP, but we can also get referrals via the A&E, and a minor percentage of it also comes from other teams, such as gynecology, amongst others. Then all those referrals are filtered through the cancer referrals office, who then books the patients either on the STT clinic that is run by 2 Band 6 nurses, which they do both upper and lower GI triage, or it gets booked into the 2-week wait clinic that can be a telephone clinic or a face-to-face clinic, and is run either by myself or by my colleague surgical consultants. Now, the patient criteria for the STT service is normally patients between 35 to 80 years old. However, we are in the process of lowering that age to 25 to 80 years old, and normally kind of a fit patient. However, that definition of fit patient can be very superficial. Then normally the nurse consultant or the surgical consultant on a 2-week wait pathway tend to see the high-risk patient. And what sometimes happens, patients do get booked into the STT clinic, but the STT nurses normally kind of vet those referrals, look at the previous medical history, looks at the GP referral, see if the patient had any recent admissions by being unwell, and they might then pass that referral into the 2-week wait clinics. Our Band 6 nurses, normally within their scope of practice, they can order OGDs, Flexi-6, colonoscopies, not radiology investigations. However, that is hopefully changing in the near future. And they can also order the colon capsules. But as some of you might know, the colon capsules requires quite fit patients and within a very specific criteria. On the 2-week wait, on the other hand, we order any type of investigation. So in addition to the endoscopy investigations, and as well as the radiologic investigations, we most of the times order CT pneumocolons, which sometimes tends to be the patients that the STT nurses triage, and patient says, I don't want to have a colonoscopy, I don't want to have an OGD, I don't want to have anything that involves a tube inside me. So then those patients sometimes do have to have 2 appointments because they get a second appointment with either myself or one of my surgeon colleagues. Then once we triage patients, once we organize the investigations, then we have this safety net, which is wonderful, which is a paper clinic or a virtual clinic where patients are booked directly into this paper clinic. So let's say if I see a patient this morning, I'm going to book him into my paper clinic in 4 weeks' time. And what I do in that paper clinic is I basically review the results of the investigations and write to the patient and to the GP with the outcome. Now, you might think, oh, 4 weeks, if the patient has a CT tomorrow, you're only going to find out about the results in 3 weeks' time. So what we have as well in place here at the Homerton is if any abnormal findings are found on a CT or on an endoscopy or any formal investigation, that department is responsible to email the cancer referrals office to say, this is flagged up, or our MDT coordinator. And then instead of waiting for the paper clinic to happen, that patient gets immediately action in terms of the findings of the investigations. Next slide, please. So benefits of this model of care. Obviously, an efficient patient pathway, a streamlined that is done by specialist people instead of having patients jumping from a clinic to another or seeing different type of professionals. From the moment the GP or the A&E refers this patient to us, they get seen, and they get seen by healthcare professionals that have the background, the knowledge and skills to triage efficiently. Waiting times are better managed. Most of the times patients get referred to the GP, and I've seen it, obviously the target is within 14 days. Our internal target within the trust is 7 days, but I have spoken with patients in an afternoon that got referred by the GP in the morning. So it's a great service when it's well managed. Telephone triage allows us to see more patients. I don't know how it is in your trust, but in mine, it's certainly very challenging to get a physical space in the outpatients to be able to see patients. So the fact that I can be in my office using my phone to triage patients certainly allows me to triage more patients and more quickly. However, as we know, telephone triage does come with its own challenge. So sometimes I feel like I'm not triaging that patient correctly. And so then I need to book him into a face-to-face appointment. And then obviously, if we are working within cancer waiting targets, then have to book the patient, which might only be in 6 or 7 days, might delay that pathway a bit. I would like to think by having nurses triaging the patients and nurses behind the STT clinics that we are giving comprehensive care. We are having a holistic approach to patient care. And as well, in terms of continuity of care, I know that the STT nurses might triage a patient, might book them for a colonoscopy. The patient might be a bit frail, might have some kind of mental illness. And sometimes they do give them a courtesy call a few days down the line saying, was everything that we discussed clear? Have you received your bowel preparation? Do you want me to go through with it? As well, patients that might be on anticoagulants that needs to be stopped before these procedures. So closer to the time that the patient is going to go undergo a colonoscopy, they might give them a call just to say, have you stopped your anticoagulants? So it's a good service, I would like to think. Obviously, the idea of this model is to improve the diagnostics, early diagnosis, time sensitive, to things to be action well timely. Obviously, as well, to use the hospital's resource wisely. Here we receive about 70 referrals a week, sometimes more, sometimes less. So we have potentially 70 patients a week that might need a colonoscopy or might need a CT, depending where they fit within the criteria. So it's about choosing wisely which investigation and liaising with those departments to ensure that we're not overstretching their capacity. And then obviously having nurses and doctors and as well a big admin team behind us allows us to give the appropriate care to these patients, timely wise care, and as well manage the increased number of referrals. What I mean by that is, for example, like I said, we might receive 70 referrals in a week, we might receive 100. So how do we cope with the increase in the number of referrals? And once in a while, I have to do an extra clinic because we're getting a lot of patients referred. So I have to be flexible in terms of my diary to be able to accommodate these patients and to be able to accommodate the increase in accuracy. Next slide, please. difficulties of this model of care. So it requires active and forward-thinking management. We have, like I said, we have a great admin team that is always on the ball in terms of the CT has been booked too late, the patient is going to breach, or this patient needs a face-to-face clinic because they have some kind of cognitive impairment. So it requires, in a way, micromanagement. And it's not micromanagement just by healthcare professionals, it's micromanagement as well by the whole service and admin team behind it. It requires resourceful communication, not within the members of the team, but as well with GPs, with patients. The challenge as well with service accuracy, like I said, the increasing number of referrals. If we have some kind of celebrity or a famous person that suddenly gets diagnosed with bowel cancer or dies of bowel cancer, you can literally have the evidence that proves that the number of referrals increases shortly after that event. So it's being able to deal with the increased number of referrals. And to be honest, I work within Hackney Borough, but I get referrals from, for example, Chelsea Borough, which is on the other side of London. And the reason why I receive referrals from that borough is because we have really good targets, we have really good deadlines, and we tend to see patients within the established timelines. So GPs do refer patients to us despite patients living miles away from us. And then you need correct referrals, you need those fit tests, you need those UNEs to ensure that the patients have a good EGFR, especially if they're elderly, if they have cardiac illnesses, if they have CKD, amongst others. And sometimes you do get referrals that they don't have fit tests, they don't have blood results, amongst other. It requires patient compliance, it requires you requesting an investigation and patient turning up to have that investigation done. It requires patients being compliant with the bowel preparation required for most of the investigation procedures. Smart use of resources, making sure, again, you're not overloading CT departments and endoscopy departments. Patients sometimes might have failed investigations and you have to repeat them, but you're also on the clock to reach your cancer waiting time target. So it's managing that. And as well, MDT collaboration, not so much as a difficulty, but as a challenge, because there's a lot of different healthcare professionals involved within this model of care. And I probably overrun my 5 minutes, but back to you, Catherine.
No worries. For you, we let you overrun. I think that the takeaway message there is it doesn't happen by accident. A lot of planning goes into that. Okay, so last but by no means least, my colleague Gerard, who I promise is not in prison, despite the background. Oh, you're on mute,
Yeah,
Gerard.
I'm not in prison, although I do feel like I've drawn the short straw, having to follow a star-studded lineup. But yeah, my name's Gerard. I'm the head of policy and influence across the devolved nations at Bowel Cancer UK. Next slide, please. So just to give you a bit of a flavour of what it is that we do. So we're the UK's leading bowel cancer charity, and our aim is to stop people from dying from bowel cancer, to ensure that they survive and thrive. And in my team, which works across Scotland, Wales and Northern Ireland, and my counterparts in England, we are leading the policy and influencing work. So just to give you a little bit of a run through how that works. So we take whatever evidence and information we can find coming through from research or from the data that's published across each of the nations to develop policy that we think will then work in the best interests of patients. We will work with health services across the 4 nations to influence them to perhaps reform their pathways or to support them if they're already making some of those changes already. If we're hitting some roadblocks, it may be that we then move into a public affairs setting where we'll work directly with governments, civil servants, parliamentarians, and try and push bowel cancer up the political agenda and make sure that any financial support or prioritisation is then coming from the top. And again, if we're hitting some speed bumps there, we'll start to engage our community through some community campaigns and trying again just to shift that dial on the importance of bowel cancer and the need for investment and support and reform of different parts of the pathway. Next slide. So obviously there's a number of areas that we try to cover. We're quite a small team, but we try to be nimble. And I'll just kind of take you through some of the key things that I think fit within this prioritisation of tackling late stage diagnosis, which is a big priority for the charity is pushing more and more people through that diagnostic pathway and getting as early a diagnosis as possible. So there's a lot of work goes in around awareness, but in terms of some of the service change, we're looking at how symptomatic fit in primary care, how's that going to influence a change within the service? What will that mean in terms of the demand further down the line within secondary care and colonoscopy? I think Laura was mentioning that earlier about the potential to perhaps have a more accurate referral pathway using FIT and what comes beyond that. So there's been some evidence come out just recently, I think it was from NHS Lothian, which was looking at the impact of double testing for people who are below the threshold of 10 micrograms per gram. We also look to support GPs and through our services team in particular, and pulling together some materials that can help with upskilling and gaining some of the knowledge within primary care about the benefits of FIT and some of the other issues around perhaps younger people and their risks of bowel cancer. Screening is a big one. That has got the potential to really switch the dial, flip things on its head in terms of emergency presentations, and screening participation is a big part of that. So there's an awful lot of work we need to do to try and understand why participation in certain communities may not be as high as we'd like to see, and really push that as high as possible. Some of the work that we've been doing, again, Laura was talking about this within England, but looking at the age range, so from 50 to 74 is what the recommendation from the National Screening Committee, but also the sensitivity of the test. So there's various thresholds that are applied across the 4 nations, and what we want to do is sort of iron out that inequality, going in line with the NSC's recommendations, and in future pushing that sensitivity threshold down to 20 micrograms per gram, and then looking at any research in future around how screening might be risk stratified to make it more personalised. But there's an awful lot of research that's required over that in the next coming years. Lynch syndrome, again, a big issue for us to look at is trying to get that understanding of people who are at higher risk, and Lynch syndrome definitely falls in there. So what's the testing like at the point of diagnosis? We're currently underway with an FOI across the devolved nations. We may be looking at something similar in England to understand what's going on there with the test at diagnosis, and then the cascade testing through families, and then looking at the surveillance and seeing that the potential for what is coming in the next couple of weeks or the next week in England, and seeing if that can be replicated elsewhere. Big issue around capacity. So there's an awful lot of work we're doing around workforce and some of the workforce planning that governments are doing. I think there's imminently a workforce plan coming out in England. I'm not sure if it's out yet. I'm sure it's been imminent for a few months now. But yeah, we'll keep an eye on that, and then hopefully support some of the development of those initiatives, and also looking at capacity around equipment, making sure there's enough equipment and that it's renewed where appropriate. And then one of the big things we're doing, working with some other cancer charities, is trying to understand inequalities and what data exists and what gaps there may be within some of that data. So kind of going straight from the beginning of the pathway all the way through to the end, through to the sort of post-treatment support. There's an awful lot of work that we do in our team, but I think these sort of cover off some of the main areas that we're focused on in terms of moving things towards an earlier stage of diagnosis.
We've got some questions. We're going to put out a plea for any questions. Do put them in that box, because we've got plenty of time to rattle through them. So the first question we have is, I think this is one specifically for you, Philippe, but everybody else feel free to chip in. So it's, how can the rates of bowel cancer diagnosis via the service model that you described improve?
Thank you. It's a great question. I think it's multifactorial. There's a lot of variance on it. First of all, going to the patient education. Are patients presenting themselves to the GP at timely, or are they having change in bowel habits for months, even years before they present themselves to the GP? And even when they do present themselves to the GPs, are the GPs referring those patients to the appropriate service, to the 2-week wait service? So it requires patient education. It requires GP education as well. And then it's ensuring that the service that you are providing, the 2-week wait service, is meeting those cancer deadlines and are triaging the patients accordingly and as per, NICE guidelines, best evidence, best practice, all that. But the fact that the service is there, you should be able to diagnose patients earlier. Evidence-wise, it's a bit challenging. We know that 25% of patients in the UK get diagnosed at a later stage. We know that that percentage of patients hasn't changed much over the last few years, despite having STT service or 2-week wait services. So those services are diagnosing patients, but are they diagnosing the patients? Is it making a dent on the patients that get diagnosed at a late stage? That's the big question there. And it requires, it's multifactorial. It's patients, GPs, trusts, all that requires for us to get a good improvement. And just for reference as well, and just to open the discussion, I'm just completing an audit now on our service that I've just done 3 months, which is about 380 patients. And out of 380 referrals, we diagnosed about 3% patients with bowel cancer. So you can imagine you have this big machine, this big system, a lot of healthcare professionals behind the 2-week wait clinics, and we are diagnosing 3%. So can that rate increase as well is the big question. Not just the late stages, but as well, instead of diagnosing 3% of those patients, diagnose like 20, 25 or even more. The fact that we are diagnosing 3% is great, but can we diagnose more patients? But yeah.
Brilliant. Okay, Laura, Anwar, any thoughts to add from your particular perspectives?
I think Philippe's absolutely right. It's multifactorial, and it is about patients also presenting because it's an embarrassing condition as well. And my clinic, it's a non-2-week wait, but our pickup rate is something about 3%, 2 to 3%, which is amazing. I was shocked. And that's probably because we have a low threshold for doing colonoscopies. The other thing I would just say, which you don't know yet, is I'm also GP lead for genomics in London. And one of the other things we're looking at is getting GPs to start recognizing family histories of Lynch particularly, because I think that is not joined up. And the quicker we can get that, and certainly with Lynch, we know there are mismatched genes, the 3 of them actually, mismatched repair genes, that are causative on it. So there is genetic testing as well. So we need to start having a multi-pronged approach.
Indeed. Jared, anything from you on the Lynch inclusion?
Yeah, I think that's an important point there that Amber's made. I think just interestingly, just yesterday in Scotland, they have quality performance indicators, and in the last round they included some QPIs on Lynch, both on the availability of testing, but also then on the referral onto genetic services. And it was one of the areas that I think there was an underperformance within Scotland compared to the other QPIs that were set out. So there's definitely some work to do within that. And I think you're right, within the primary care setting, being aware of what else is happening within the family and what that means for an individual's risk is quite important. Yeah.
And I think that leads us quite nicely into another question that we've had. Anwar, you talked about patient compliance, as indeed so did you, Philippe. And that's how, and this is a question that is the bit of the holy grail for Bowel Cancer UK, because if we can find the answer, then great. How do we encourage people to watch out for signs of bowel cancer and actually go to the GP? It's the going to the GP bit is a question that's come in. So Anwar, shall we start with you?
I think I don't know the answer. If I did, I'd be millionaire. I suppose a couple of things occur to my mind. One is if patients have a good experience from the colorectal clinics themselves, they're going to spread the word that it's actually not that bad and it's not that painful. And so I think we in the clinical setting have a role to fulfill to make that experience. It's not an embarrassing experience, but as feasible or as possible. I think the other thing really is GPs should be thinking about bringing stuff in early, especially the poo test. as we call it, because I think people don't like messing around with poo and putting stuff in. So I think being positive, GPs can give a positive message that actually it looks messy, but actually it's critical. And I think the most important message we need to give out, and when I was chair of the CCG in Waltham Forest, we actually got the local newspapers to start saying, you know, it may be embarrassing, but bowel cancer picked up early, we can cure it. Whereas brain tumors you pick up early, it probably won't be curable. So I think that's the other message, really.
Yeah, Laura, I wonder if you have a view from where you sit on this, because poo tests and doing things about it must be something you spend a lot of time thinking about.
Yeah, we have a big promotion specialist work happening, and especially, you know, in Northeast London, we got lots of different ethnicity, and they all have their own issue about pooing, and that part of the body they don't want to talk about. So we'll be doing proper tailored targeted to different community, you know, health promotion activity to help with that, because it's definitely very important. And what I think it also that helps, because we tried different models and some of them didn't help at all, but it's properly, you know, getting the voice out of the story of some of the community. They say, actually, I've done it, I had your same view, but actually, thank God, my wife pushed me to do it because I didn't want to do it, and I found this polypearly, and, you know, bring out the message of people within their community. We're lucky because we have also some of our specialist nurses, they are part of the community. So we got a Turkish nurse that can go into the community, we got Bangladeshi. So it's very important to go into that and target that side, because, you know, I have lots of patients and tell me, you know, that nobody wanted, that he didn't want to do it, and it's done, and I keep on saying, go back and tell your friends to come as well. There's not been that bad, spread the news, because that, I think, you know, as much as a promotion we can do, as much GP can say, as much we can put in the radio and the newspaper, you know, that word of mouth is actually the one that convinced them to do it.
Yeah,
ultimately.
there is something very powerful, isn't there, about health advocates within particular communities in shifting the dial and changing behaviour.
But definitely lots of work, you know, we our health promotion specialists are very, very, you know, working on that. And anybody has an idea, please do contact me. I can pass on to Lina. She's always very happy with new idea and getting people on board to help in that way.
Fabulous. I think Bowel Cancer UK will be reaching back out to you all, asking for tips, because we're planning our big awareness roadshow, and that a big part of that is, you know, finding those champions for us within the different communities who can really land that messaging. So we now things are hotting up on the question front, so we've warmed you up nicely. So this question is from Lindsay, who says, more and more I'm seeing patients with GI concerning symptoms who are not being referred on the 2-week wait as their fit test is negative. So they've been given GP or somebody, that there's sort of false reassurance happening because they've had this negative test. So do you currently have the fit test added onto the 2-week wait pathway? And if so, what level of fit positive, as they've had lots of differing advice and are really interested in the view of the panel?
I can take that one if you want, because one other thing I do, I'm part of the London Endoscopy Clinical Leadership Group. And we've been actually working on the 2-week wait pathway for that reason that we were discussing, because the old pathway based on the NICE guidelines about symptom in different age only picked up 3-4% of cancer. So you do all this work and then actually you pick up. It's the same as a standard symptomatic normal GP surgery clinic. So actually fit is very, very good. So the data that we created this new algorithm that should come, you know, shared very soon, because it's now been approved nationally, where fit is really important. So we use a cutoff 10, although the evidence is that basically if you use as cutoff 7, you need to do only 11 colonoscopy to find 1 cancer, and the risk of missing a cancer is only 1 in 1,000 that's got a fit less than 7. And actually that improves even more if you take in consideration patients without iron deficiency anemia, because in the big trial they've done, like QFIT, the one that had a fit less than 7 with cancer was the one that still had iron deficiency anemia, so you can't regain that in that way. And fit is really important. I mean, as Gerard was saying, actually, there is no evidence that if you do 2 fits, you gain even more. The problem is getting the patient to do the fit. The algorithm that will be shared very soon is actually, quite clearly saying what to do. Obviously, fit, if you got the symptom, you do fit, the fit is positive, that's straightforward. If the fit is less than 10 without anemia of any type, not just iron deficiency, then if you're still worried and you still got some concern, then you have to think about other pathway. Is this another cancer? So it's like a pancreatic cancer. Does this require a different type of 2-week wait? Or is this a different condition? Is your patient young? Should you do a calprotectin? Is this inflammatory bowel disease? So that algorithm show you all that different though. And if you're still worried, then you can still go to the RDS clinic where you are concerned, but there's no specific organ involved, and you can still catch up with that. So actually, these algorithms try to, improve that 2-week wait pathway to try to reduce the number of colonoscopy we do with a very, very low detection rate.
Interesting. Any other thoughts from the panel on that?
I would just add just to what Laura's saying. I think it's really important that they're aware that FIT is definitely a really important tool that can be used with referral, and obviously that evidence around the double testing will be interesting to see how that develops, because there are those other things that can be looked at, like, as you say, with IBD, and there's reforms to those pathways. I think the BSG have endorsed within the last year as well. So there's a different safety net and protocol underneath that. And at the end of the day, it comes back to that clinical gut of GPs to understand the relationship with their patient and what's going on there. So I'm sure Amar might have some thoughts on that side of things, but yeah, I think QFIT is a useful tool. It's definitely something that adds to the picture when it comes to referral.
I think the thing that I find is that some people are just using a FIT as a screening thing and not actually asking patients, and it's embarrassing. And I often find when people have been sent, they don't fit the criteria, excuse the pun, but then they come to me, and when I inquire more, there are symptoms. Well, I have lost a bit of weight. My belt is a bit so, and I think that's where the history is still very important. And I just worry that some people are just going for tests to replace history taking. And I think tests should augment the history rather than replace it. Sorry, I'm just being provocative, but I've certainly found a number of patients where I found worrying signs when I've actually seen them in the clinic.
I definitely agree. In fact, the form doesn't say do FIT for anything, because we get referral of patient having migraine and had a FIT and it was positive. The FIT should be done only when you have a symptom of bowel cancer, which are the old nice, and 12 symptom of abdominal pain, change in bowel habit, etc. So definitely not FIT to anybody, but after a good history.
Great, thank you, everyone. Yeah, I think that's a debate that could rumble, isn't it? And no doubt will change quite a lot with the things that are coming down the line. I think this one might be a question for you, Philippe, because I think it refers to your slide. It's how do you meet the find out faster target if non-cancer results are reviewed 4 weeks after they've happened?
So it's a great question. And actually, looking now at my clinic, my next paper clinic is only in 6 weeks' time because it's fully booked until then. So normally, to be honest, if there's anything non-bowel related, for example, an enlarged nodule or a mass somewhere else, we still get notified by it. And actually, sometimes we don't get notified by it. Actually, the radiologist consultant emails directly the MDT more appropriate for that type of finding. But there is a lot of non-cancerous or benign findings that do get picked up only about 4 weeks after. For example, in my paper clinic tomorrow, I already know I have a patient that has a 10 centimeter ovarian cyst that is most likely a cyst, but was picked up on a CT and most likely needs an ultrasound. But, in the end, you're running a bowel cancer 2-week wait service. And your mission here, if you choose to accept it, is either diagnose or rule out bowel cancer. And there's that old saying that if you look, you will find. So if you're doing OGDs, colonoscopy, CTs to a patient, for sure you're going to find something, especially if there are kind of elderly patients. And, you know, you're going to find lots of things. You're going to find diverticular disease, you're going to find hemorrhoids, you might find IBD, you might find colitis, all non-cancerous type of things. Ideally, I would like patients to have their investigations in a week, and then I review their results the following week. But, you know, to run that type of service, I would need to have 5 or 6 colleagues of mine to run the same clinics as I do. But yeah, I think the mission here is either to diagnose or ruling out cancer. All the other benign, then you pretty much either do more investigations or you refer back to the GP and you let the GP take the lead on anything else that is needed.
Great, thanks, Philippe. I think I just saw another question pop in because there is one that I do want to ask, even though it takes us slightly away from early diagnosis. But I think I just saw another one pop in and I want to check. No, I can't see it. Okay, so this question is, are there any initiatives around living with colorectal cancer and recurrence? So it's, are there services available to bridge the gap between primary and secondary care, i.e. specialist nurse-led clinics? And I imagine, Anwar, probably this is sitting with you to start us off, because it's that continuity of care piece, isn't it?
It is, and we don't actually have the stoma nurses I'd love to have in that. So there is a break in that. So we're using our consultant networks to go through. Ideally, I'd love them to be sitting in our primary care clinics. Really.
Yeah, interesting. Anyone else, Philippe?
We do, obviously, like most trusts do, we have health and well-being events for our patients where we invite them. Certainly during COVID, those got all cancelled, so some trusts are still kind of trying to resume those events. But, you know, not necessarily for metastatic colorectal cancer, but for any type of patient that got diagnosed with colorectal cancer, we have health and well-being events. The last one, we got a dietitian, a physio, and other key stakeholders to come and give talks to patients to help them with that area that is living well and beyond cancer. And obviously as well, Bowel Cancer UK has many different types of forums and initiatives to help patients as well.
And that's actually one of the areas that we're looking at, is those how we can help trusts and hospitals offer that health and well-being intervention in a way that is as easy as possible. So we have the recorded content from all of those experts that you've just talked about, and we're looking at ways that we can offer that virtually, so that you can perhaps have nurses present in the room with patients to answer questions following watching the video. So lots of innovative ways we're thinking about how we can make it as easy as possible for nurses to deliver that stuff when it's probably one thing on a very, very long list. Any other thoughts on that? Okay, so I'm going to ask one more question, and I'm going to go with what future developments do you see happening in the straight to test service arena?
You want me to say something? Just crack on and then follow. I mean, we had lots of discussion within our group. I mean, initially we were trying to combine the lower GI straight to test pathway with the upper GI. So the problem that it was getting quite complicated. I think that we nearly given up on that. I mean, from the straight to test point of view, it's mainly the triage and the patient education. So the new form you got top tips up at the top for GPs, you got the link to the advice and guidance when they can ask directly question if the patient doesn't fit all in it. And you have the link to the NICE guidance, the link to the local algorithm about it, etc. So that's more from the referral pathway point of view. I don't know if Felipe wants to do anything else from a service point of view.
Obviously, my vision, after showing you the model of care we have here, my vision, and that's because of, obviously I believe in the power of nursing and in advanced practice, would be to have, in a way, a nurse-led service. We would have advanced practitioners that would triage patient, request investigations, and would do the paper clinic. So everything would stay within one person, the care of that one patient within one person, and that would be great. But that's, again, is multifactorial. It's going to depend in finding the right people, having the right money for it as well. For example, our 2 STT nurses are funded by the Northeast London Cancer Alliance, and they are in 1-year contracts that pretty much they're not going anywhere, but every year we have to renew the contracts, meaning to develop them from a study leave point of view, to get them to develop to that band 7 or even a band 8 level. I need them to be kind of in permanent contracts, but we still develop them, but it just makes it tricky when you're trying to planning a service that is on a recurrent 1-year contracts. But that's kind of my vision and how I would like, and I know there's services out there already that are pretty much nurse-led, but my personal view for this service we run here is to be nurse-led. Obviously, we still need the consultant's input because, like I said, there's so many findings that, sometimes I have to call my colleagues to know what does this mean because it's not Bowel related. But that's what I would like to see things going.
Thank you. Any last thoughts from anyone, either on that or on anything else that we've covered today?
Yeah, Catherine, if I could just add, I think just to the point that Philippe was making there, I think there's a number of different factors that come in to that. And I think, as I'd said in one of my slides around workforce and investment in workforce is absolutely critical across all 4 nations. We know that demand is increasing. I think what's really important from our point of view, at least, is that governments are looking ahead and trying to look at what demand is going to be in the future. It's a big enough challenge trying to meet demand now, but if efforts are put just to try and meet today's demand, then you're going to fall short when you come 10 years down the line. So there's a big job for us as patient advocates and also working in partnership with clinical colleagues to make that argument across each of the nations to say, this is what you need to be investing in. It's the people, it's the services, and given the space and the capacity to try new things. And I think that's really, really key, because if not, it's constantly going to feel like hitting your head off that brick wall behind me.
That's why the wall is there. Lovely. Right. Well, thank you. Sadly, we are out of time. From me and everybody watching, and on behalf of Bowel Cancer UK, I want to say a huge thank you to Philippe, Laura, Anwar and Gerard for giving up your time this afternoon. So that's it from all of us. Look forward to seeing you at the next one and hope to meet lots of you in person in Birmingham. Take care, everyone.